Hello class. I'm going to start week 3, day 1 lecture with you today. Our concept is immunity and our exemplar is wound care. Just want to talk first a little bit about immunity. What is it? And this is a perfect time to discuss immunity since we all know what we're going through worldwide with this pandemic of the coronavirus. But immunity is basically our body's natural or induced response to infection and its associated conditions. And many of us, if not all of us, have an immune system that defends and protects the body from infection and helps to remove and destroy damaged or dead cells, and it also identifies and destroys malignant cells as well. Now we know, and I'm not going to get into a lot of detail, that one part of our immune system is our white blood cells. And we have various types of those in our body that do a specific job. We have such white blood cells as leukocytes, and then we have granulocytes, which is the classification of white blood cells such as monocytes and lymphocytes. Our granulocytes are our neutrophils, our eosinophils, and our basophils, and our lymphocytes are our T cells, our B cells, and our natural killer cells. I'm not going to go into a lot of detail, but I just want to familiarize you with the various types of white blood cells that we do have within our bodies to protect us against any type of infection. And there are terms such as antigens and antibodies, which is very big in the news right now when we talk about antigens being large protein molecules that provide a specific reactivity. And then there are primary and secondary immune responses, and of course antibodies, which are those immunoglobulins. And you might be familiar with this from your A&P class, IgM, IgG, IgA, IgD, and IgE. I'm not going to get into detail, but I'm just familiarizing you with some of the things and defenses that we have within our immune system. And then of course there's the lymphoid system, which includes the lymph nodes, our spleen, the thymus, and our tonsils as well. And with our lymph nodes, that's probably one of the most common defense mechanisms that we have. They're about 1 millimeter to 2 centimeters in size, and those filter products or antigens from the lymphs to house and support the proliferation of lymphocytes and macrophages. Our spleen is the largest lymphoid organ. Within that spleen, we have different colors of pulp, which provides a certain job within that spleen. White pulp within the spleen has B cells, which predominantly has B cells. And then of course your red pulp is where you have blood filtration and damaged or aged red blood cells, platelets, stores bloods. And remember, your spleen is not essential for life, but it just gives you that added immunity. And your thymus is in the mediastinum, that cavity beneath the sternum. And then your bone marrow, which produces many of these cells needed to protect you against infection. The lymphoid tissues, tonsils and adenoids, and then of course non-specific inflammatory responses within the body would be skin, tears, urine, acid in the gastric fluid, zinc in the prostate, lysosomes in your tears, nasal secretions, saliva, and sweat. So just to refresh your memory about the many systems that are in play to protect us against infection and disease. So let's look at this PowerPoint right now, and our concept again is immunity, and our exemplar is wound care. And when any person or one of our patients develops a type of a wound, our goal is to hope that that wound that can heal properly. And we're going to talk now in the following slides about the different types of wound healing. Let's first look at primary intention healing, and this is where the tissue surfaces approximately are closed, minimal or no tissue loss. An example of this would be the surfaces look very well approximated. This could be a closed surgical incision or some kind of tissue adhesive like glue, or maybe even like steri-strips as well. Nice clean wound, which is intentional. Might be some type of surgical procedure that's done. And again, the tissue surfaces are approximated with little or no loss, and these are the examples. Closed surgical incision and tissue adhesive. So hopefully that makes sense to you. All right, let's look at secondary intention healing. This is more of an extensive type of injury to the skin and involves considerable tissue loss. The edges cannot or should not be approximated, and an example of this would be a pressure ulcer. All right, and lastly, we talk about a tertiary intention healing. This is a very serious wound in which probably has a lot of exudant within inside of that wound, so we leave it open so that can all drain out, and it allows the edema, which is the swelling, the infection, to resolve, and with leaving it open allows all that drainage to come out, and then we eventually close it. There are also phases to wound healing as well. And of course, once an injury happens, this is what exactly happens during that whole process of trying to heal. First, there's inflammation, or the inflammatory phase, which happens in approximately the first 3 to 6 days. This is where hemostasis, phagocytosis occurs, deposition of fibrin, cell migration of the macrophages. The second is the proliferative, happens in about day 3 to 4 to about day 21, and this is where collagen starts to build up, and this is a good thing because this actually adds strength. Capillaries increase to bring better circulation to the area for better healing, and then of course granulation of tissue. And lastly is the maturation or the remodeling phase, which can happen at about day 21, and it can go on as long as 1 to 2 years. And this is where you have keloid, which is another way of saying scar tissue develops. So those are the phases of wound healing. Okay. Now, of course, with any type of wound, there's always the potential for complications. And the first one, of course, is hemorrhage, where the area could bleed a lot depending on the location, and if major vessels are also involved. Hematoma can occur. And of course, with any opening within the skin, we always have the chance of infection, where there's a contamination with some type of microorganism, which is usually inevitable. And then we have these certain issues and problems or complications occurring with a wound. And one of them is what we call dehiscence, with possible evisceration. And a dehiscence is basically a partial or total rupture of a sutured wound. This might be, say for instance, someone has an abdominal type of surgery or an abdominal wound, where the below layers start to separate. And then we have evisceration, which makes it even more serious, where it's the protrusion of the internal viscera that starts to come through from the incision. This could occur due to some type of trauma, or else if someone is violently coughing, all that pressure will cause an evisceration of the wound. Someone who's dehydrated, an obese person is more at risk for having an evisceration occur, and also poor suturing, where maybe there was poor technique back in the OR, and so it was not properly sutured or stapled correctly, and the wound opened up and eviscerated. So we know too, with these wounds can come some exudate, which is a fancy term for the kind of drainage or the material that comes from that blood vessel, which deposits in or around the tissues. There are 3 types of exudate, and this is where it comes into play that you as the nurse really pay attention to this exudate and definitely document exactly what is draining from the patient's wound. The first one is serous, which usually occurs with some mild inflammation. It manifests as clear, sometimes even straw colored. It's very thin and watery fluid, like you get from a blister. That's what we mean by serous. And then we have purulent, which is more of a opaque or milky type of pus that comes from the wound. And then of course sanguineous, which is more hemorrhage involving a lot of red blood cells, and many times you might have a mixture of these, and we might better know that as like a serosanguinous type of exudate coming. So it would be very thin and watery combined with more of a bloody type of drainage, and usually as that wound begins to heal you might see that bloody type drainage start to get less and less, where it becomes more watery, and that's a good sign that the drainage that's coming from the wound is decreasing. And again, looking at lifespan and cultural considerations, older adults are more likely to have chronic diseases, and of course a lot of these complications will depend on a person's status of their nutrition, because when they are deficit or having just deficiencies with their nutritional intake of certain proteins and carbohydrates and vitamins, they're more at risk. They also have a delayed inflammatory response and the same quality of healing in older and younger adults. But unfortunately, older adults' process may be slowed down, maybe take longer for that particular person for their wounds to heal. So something to think about. And it's just knowing a little bit about your patient's history and their health history. And of course, we know our diabetics as well take a lot longer to heal as well. And of course, it can also depend on what medications they're on as well. These are some of the non-pharmacological therapies, infection prevention method measures, vacuum-assisted closures, some cellular therapies, biosurgery, positioning, and certain nutrition. And we may, give these patients what we call TPN, or total parental nutrition, where it has a high amount of protein and certain vitamins, depending on a patient's chemistry, especially if they're deficient in those particular nutrients, that they might put the patient on this to better promote healing for the patient as well. And many times to diagnose some of the problems that the patient's having, especially if wound healing is really not occurring as fast as the healthcare provider would like it to. They may take that drainage or whatever exudate is coming from the patient and do a culture and sensitivity to see what exactly is the causative organism, or maybe surgery is necessary to repair the wound by maybe debridement. If a patient has wounds caused by burns, they might do what you might know as an eschariotomy. And then, of course, sometimes with these injuries, a patient may have compartmental tissue damage where there's a lot of fluid accumulation, a lot of edema, which can restrict blood flow, which could be a very serious situation to that particular area of the body. So surgery may be needed for that as well. And of course, with non-pharmacological therapy, there's also the possibility of pharmacological therapy, which you're learning in Nursing 123, such as antibiotics, growth factors, and with some of these wounds comes a lot of pain and discomfort. So of course, to manage their pain medications as well. Sometimes, as well as these non-pharmacological therapies that are on the screen, there may be such very aggressive therapies such as hyperbaric O2 therapy. They've also been known to use sterile maggots, stem cells, and skin grafts as well. So that's just a little overview of some of the important terms and facts about wound and wound healing, and of course the phases of that wound healing as well. And just generally, it's important to remember that most healthy children and adults will heal more quickly than do older adults, who are more likely to have some of these chronic diseases that kind of hold back that person from healing as quickly as we'd like them to do. Don't forget about people that may have liver function problems that can impair the synthesis of blood clotting factors. We know that they have definite nutritional deficiencies, and because of that, maybe not getting enough iron in their diet, they may reduce the number of red blood cells and leukocytes that impede the delivery of oxygen. And of course, the inflammatory response is essential for wound healing. And of course, people with lung problems, diabetes, and any type of cardiovascular disease also impairs oxygen delivery to those body tissues that need it so much for the healing process to occur. And as one gets older, there are always the chance of atherosclerosis and, of course, atrophy of the capillaries in the skin, which again impairs blood flow, which is to the wound, which is absolutely essential for wound healing. Now, even though some of these older adults may not have many of the chronic diseases that I've just talked about, they still will experience more of a slower healing process because of just the aging process and the normal cellular and molecular changes that occur. And we know for sure that with older adults, there is a delayed inflammatory response with fewer of those white blood cells, and of course that phagocytosis process that occurs to prevent the infection from happening or to help it heal much more quickly. There's also cell renewal, and collagen synthesis is also slowed with age, and we know about the changes in the vascular system. There's also the thought of the aging skin that has a definite impact on the healing process, but also makes the skin more prone to damage from pressure, friction, and shearing. and scar maturation appears to be improved in comparison to the younger individuals as well. Now let's talk a little bit about the younger generation. We can't forget about the newborn, the infant, or the child. The skin of a newborn and an infant is much more fragile than that of an older adult, and adults is more susceptible to infection, shearing from friction and burns. We see a lot of times that kids are very sensitive to certain things that they come in contact with, and may have areas of irritation, surgical wounds, pressure injuries, or shear, maybe an IV infiltration injury as well. Obviously, premature babies are at greater risk for any type of injury to the skin, because that skin has not matured as well, and it's very, very, very fragile. And this population is also at greater risk for bacterial and fungal infections due to the fact that they have a decreased immunity system as well. The two major infectious agents affecting the skin of children are Staphylococcus and fungi. And I'll be honest with you, I did not know that, so I thought that was very interesting that your book pointed that out. Abrasions or small lacerations, commonly experienced by children, will provide another entry for these organisms to actually make the person develop problems. So just wanted to kind of remind you not only about the older population, but also consider what the integrity of the skin is within the newborn infant and within kids as well. All right, class, now I'd like to go over this Appendix 13. Again, staying with our concept of immunity and looking at our exemplar of wound healing. We have just a very short case study here with just a couple questions that I want you to think about. The case study involves Lydia Ocampo. She's 69. She wakes during the night to urinate, but she falls on the way to the bathroom. An ambulance takes her to the emergency department, where she is diagnosed with a left hip fracture. She is sent to the operating room for an open reduction internal fixation of the left hip, and she is admitted to the medical surgical floor following surgery. Now, Mrs. Ocampo remains at the hospital because she has developed an infection in her incision and needs intravenous antibiotics and dressing changes. Her oral intake has been inadequate, but she has been well hydrated by the intravenous fluids. She has been incontinent ever since the Foley catheter was removed. Attempts at physical therapy have been unproductive. The physical therapists are successful at transferring her from the bed to a chair, but this requires nearly full assistance. So now we have a problem. She had to have surgery, and of course that surgical wound has now become infected, and we can see that a lot of other problems are occurring as well. All right, so let's look at question 1. Identify priority nursing diagnoses for Mrs. Ocampo. So think about what her problems are. She has impaired skin integrity as evidenced by infected surgical incision, of course. And we don't know a lot of the details about that. We don't know, what kind of drainage is coming from that. If the patient is experiencing a lot of pain. But we do know that it has evidence of infection. She also has impaired tissue perfusion as evidenced by infected incision. She also has a history of Alzheimer's, which you didn't know about, but this was a character in our my nursing lab, and Lydia Ocampo is beginning to show signs of dementia and Alzheimer's. So she has chronic confusion, which is probably a lot of the reasons why she's not drinking enough, and she's been incontinent as well. And of course, impaired urinary elimination is evidenced by incontinence. And we could also include that incontinence as impaired skin integrity, particularly with sometimes we see with a person who's frequently incontinent start to have irritation and skin breakdown because of the urine, and the waste products present in the urine can also cause skin breakdown as well. Question 2. List factors that put Mrs. Ocampo at risk for alterations in skin integrity. Obviously her incontinence, which I just got done talking about. What else? She's not getting up, and she needs full assistance just to get from the bed to the chair. So that is going to affect her tissue integrity. Her immobility. She's confused. All she's getting at this point is IV fluids, which will help with hydration, but she's not getting all the proper nutrients for proper healing as well. And she's really having a hard time with the physical therapy, which at this point is pretty unsuccessful because it's taking a lot of physical energy to get this patient up from the bed to the chair. So you can see when that affection occurs, and especially with someone who is at a high risk, which Lydia Ocampo is, we see now many serious problems are starting to develop because of the infection and her prolonged hospitalization. So that's Appendix 13 with Lydia Ocampo. All right, class, because you're so smart, let's practice these NCLEX style questions about wound healing. First question is, an older client had abdominal surgery that has not healed after several weeks. The client asked the clinic nurse why it is taking so long for the wound to heal. The nurse would explain that which of the following is a factor that negatively affects healing in older clients. Great question. And these are our choices. Number 1, vascular changes decreases the blood flow to the wound. Number 2, most older clients are overweight. Number 3, decreased activity levels prevent blood from reaching the area. And number 4, keloid formation prevents healing. Now let's think about that when we're talking about the older client. Give you a few minutes. I know you know this. You guys are really smart. All right. The answer is number 1. Vascular changes decreases the blood flow to the wound. I just got done talking about that when we're comparing older people to the younger generation. Okay? Good job, everyone. I know you got that question right. And the rationale behind that question is vascular changes such as atherosclerosis and atrophy of capillaries in the skin impair blood flow to the wound. Older adults are not necessarily overweight, and decreased activity does not impede blood flow. And a keloid is an abnormal type of wound healing. Remember, that's what we call basically a scar tissue. Okay? Good job, everyone. Good job. All right, let's go to question 2. The nurse is explaining wound healing to a client in the family prior to the client's abdominal surgery. The nurse tells the family that the best type of healing for the abdominal surgery is number 1, tertiary intention, number 2, secondary intention, number 3, stage 4 healing, and number 4, primary intention. Now think back, that was at the beginning of my lecture. So which one would this involve when we're talking about a surgical type of wound? And of course, I knew you all knew this. It is number 4, primary intention. Good job, everybody. And again, the rationale behind that is primary intention is healing that takes place with a wound with well approximated edges that is closed after surgery. Tertiary healing or intention occurs with an open, ragged, edged wound in which the secondary healing becomes infected. Secondary and tertiary intention wounds are open and healed by granulation. All right, let's go on to question number 3. The nurse is working with a post-op patient who dehisced a wound after a previous abdominal surgery. The nurse plans interventions to promote wound healing and prevent another dehiscence by... Now think about all the many causes in which dehiscence would occur. So that'll give you a little hint as to how to answer this question. And of course our choices are: number 1, assisting the client with weight loss; 2, preventing emesis; 3, administering antibiotics; and 4, keeping the wound dry. And remember I said coughing with that intra-abdominal pressure increasing would cause a wound to dehisce. The same would go for someone that would possibly be vomiting. So our answer to question number 3 is preventing emesis. Again, you would build up that intra-abdominal pressure, possibly pulling that wound that's been surgically repaired or whatever, and preventing the possibility of a dehiscence occurring. I knew you knew that. Just have to think a little bit. And the rationale behind that is activities that are likely to cause dehiscence are vomiting and coughing because they increase intra-abdominal pressure. And since the client is already post-operative, losing weight is not an option. Antibiotics will not keep the wound from dehiscing. Keeping the wound dry will risk pulling on the surgical site as the skin dries out and will increase the risk for dehiscence. So dehydration is a possible risk factor as to why someone may dehisce. All right, I hope you found those questions helpful. Great job, everyone. I'm sure you did very well in answering those. Remember, these are all uploaded in your Canvas course now under week 3, under modules. Class, before we do this activity, I'd like you to look in your Canvas course in week 3 under modules and notice that there is a YouTube video on isolation techniques. It is very good. I could play it for you now, but I'm just concerned that we'll have that echo and that overlap of audio on there, just like I did with one of my other videos, and I don't want that to be a distraction for you. So before we do Appendix 14, I'd like you to watch that isolation technique video. It's very good because it talks about airborne precautions, droplet precautions, and contact precautions. And this is just so appropriate now with what we have going on in the world. And so many of you may be working in healthcare, and this could, even shed a lot more light and information about why we do what we do. Let's talk somewhat a little bit about isolation. And those are the cautionary measures that we use to prevent the spread of infection or some potentially infectious microorganism to health personnel, to other patients, and even to the visitors that come in and see these patients. And each one of these particular types of precautions have their own set of guidelines that we definitely want to see and used and enforced in hospitals or other healthcare settings. We talk about the term universal precautions, and those are techniques to be used with all patients to decrease the risk of transmitting unidentifiable pathogens. And universal precautions obstruct the spread of those bloodborne pathogens, microorganisms that's carried in the blood and in bodily fluids that are capable of infecting other individuals with serious and difficult to treat viral infections. And one of those that we know is your hepatitis, especially the hepatitis B virus and hepatitis C virus, and even the HIV. The CDC recommends not that universal precautions replace disease-specific or category-specific precautions, but they must be used in addition to those particular precautions used for that particular organism. And The body substance isolation system employs generic infection control precautions for all patients except those with a few diseases transmitted through the air. And this body substance isolation system is based on three premises. And the first one that your book talks about is that all people have an increased risk for infections from microorganisms that enter through the mucous membranes and non-intact skin. Number two is all people are likely to have potential infectious microorganisms in all of their moist body sites and substances. And then number three, an unknown portion of patients and healthcare workers will always be colonized or infected with potentially infectious microorganisms in their blood and other moist body sites and substances. We know our CDC has been in the news quite frequently, especially when we're talking about the coronavirus. I want to talk about the three types of precautions that this video that you've hopefully watched by now gives you specifics as to what type of personal equipment you need in order to carry out fully the necessary type of isolation that helps prevent the transmission of this particular organism. The first one I want to talk about is your airborne precautions. And those are used for patients who are known to have or suspected of having a serious illness that's transmitted by airborne droplet nuclei that is smaller than 5 microns. And that's really, really small. And what type of illnesses transmit their particular organism in that way? And one is the measles, or rubiola, varicella, and tuberculosis. And so that's airborne precautions. Very, very small organisms that kind of stay in the air. And then droplet are used for patients who are known to have or suspected of having a serious illness that's transmitted by particles that are larger than 5 microns. And what we mean by droplets, they're a little bit heavier than the less than 5 micron microorganisms. And so they gravity kind of pulls them downward and drops them. So examples of such illnesses are diphtheria, Mycoplasma pneumonia, pertussis, mumps, rubella, influenza virus, streptococcal pharyngitis, pneumonia, and scarlet fever. And then the last one is contact precautions. Probably we use this one most frequently. It's used for patients who are known to have or suspected of having serious illnesses that are easily transmitted by direct patient contact or by contact with items in the patient's room, such as their bedside stand, might be on their personal property. And according to the CDC, such illnesses include GI problems, respiratory, skin, or wound infections, or colonization with multi-drug resistant bacteria. Specific enteric infections such as C. diff, and that's probably one of the most common things we do see in hospitals or healthcare settings. And then E. coli, Shigella, and hepatitis A, and enterohemorrhagic patients, any patient who wears diapers or who are incontinent, some type of respiratory viruses, and any type of enteroviral infections in infants and young children. And even things such as herpes simplex virus, impetigo, pediculosis, and of course scabies. And it makes sense because those would be spread by touching them and then touching your skin. It's contact. All right, so those are the three that video that you watched talked about. Your book goes on to talk about isolation practices, and I think it's important too that we're doing other things with our patients when they are in isolation. And in addition to really being sure that all the necessary precautions are taking place when they're in that particular type of isolation, we must also be aware to be aware of and to use strict aseptic technique when performing any invasive procedure, such as inserting an IV needle or catheter, or else when we might be doing dressing changes. Change IV tubing and solution containers according to hospital policy. Check all sterile supplies for expiration date and intact packaging. Prevent urinary infections by maintaining a closed urinary drainage system with a downhill flow of urine, making sure that the bag is below the patient so that urine is flowing downward. And keep the drainage bag and spout off the floor. And of course, implement measures to prevent impaired skin integrity and accumulation of secretions in the lung. Encourage our patients to move, to cough, and to breathe deeply at least every 2 hours. Okay? So let's talk a little bit about personal protective equipment. We know how important gloves are. And when should they be worn? And that is an excellent question. Many times it's necessary to know whether or not those gloves should be clean or just sterile. When do we use gowns, masks, respirators, and protective eyewear? 3 reasons why we should be wearing gloves. Gloves protect the hands when nurses are likely to handle any body substance. And gloves reduce the likelihood of nurses transmitting their own endogenous microorganisms to individuals receiving care. Nurses who have open sores or cuts on their hands must wear gloves for protection. And gloves also reduce the chance that nurses' hands will transmit microorganisms or a fomite from one patient to another patient. And obviously, nurses must change gloves between patients, and nurses should clean their hands each time they remove gloves for 2 primary reasons. The glove may have imperfections or flaws that may have damage during wearing, allowing those microorganisms to enter, and the hands may become contaminated during glove removal. And some of the gloves used in infection control are made of latex, as are various other items used in healthcare, such as catheters, blood pressure cuffs, rubber sheets, IV tubing, stockings and binders, adhesive bandages, and dental dams. And many of our patients might have a reported allergic reaction to that latex. So what about gowns? Nurses wear clean or disposable water-resistant gowns or plastic aprons during procedures when their uniforms are likely to become soiled. And again, the gown prevents contamination from one person to the next. Your book has a nice recommended isolation precautions in hospitals when we talk about standard precautions, airborne, droplet, and contact precautions. This is on page 572 in box 9-2. There's also information about face masks, respirators, eyewear, and how do we dispose of some of this soiled equipment and supplies. So that's important to know as well. So make sure you read through that and understand some of that important information. And it's just so appropriate to read this now that we have all this going on within our world with the COVID-19 virus. In class, be sure you read the pages from 563 to 565. Very appropriate as well to look at the stages of the infectious process, where we talk about the incubation period, the prodromal stage, the illness stage, and the convalescent stage. So make sure you go through that, and then look at what the complications of some of these infectious diseases may be. We know that the big one with any type of infectious disease is sepsis, which is when bacteria becomes present in the person's blood. And so that's one that we hope does not happen because even my experience with working in intensive care, septicemia may lead to septic shock, a state of a life-threatening situation where a patient's blood pressure may be extremely low that's caused by this overwhelming infection. And of course, if it's not treated correctly or even aggressively, it can lead to tissue injury and eventually to major organ failure as well. Look at healthcare associated infections. And understand what those mean. Okay, and those are pretty much those types of infections that occur when a person becomes a patient in a healthcare facility, okay, either a hospital or a nursing home. We know the respiratory complications have become a very common type of healthcare associated infections as well, because of the fact that many times patients, especially in critical units, have patients on mechanical ventilators. Many of them may also have tracheostomies or have an endotube in for intubation. And unfortunately, what occurs when these patients are on ventilators is the fact that they develop what we call ventilator-associated pneumonia, or VAP. So read a little bit about that. And another healthcare-associated infection is UTIs. It's probably one of the most common types and the most frequent cause of gram-negative septicemia in hospitalized patients as well. C. diff, which I'm going to talk about today with this lecture, is another one that you're probably all familiar with, because many of our patients have a primary infection in which they're being treated by antibiotics, which puts them at risk for developing C. diff. So read about healthcare associated infections, where we see that many do come from patients that are on surgical or medical ICUs. And the microorganisms that cause a lot of these healthcare associated infections can come from the patient themselves or from the hospital environment and the hospital personnel, which we call those exogenous, okay? And most of them appear to have endogenesis sources. E. coli, Staphylococcus aureus, and Enterococco are the most common infecting microorganisms. And we know that there are many reasons why people unfortunately develop these healthcare associated infections. One of them is because of some diagnostic or therapeutic procedure, and that might be because a person has a central line put in, okay? Another factor that contributes to the development of these infections is that there is a compromised host. That is, the people that are in the hospital, their defense mechanisms are obviously decreased or lowered because of their illness itself, or because they maybe just recently had surgery, all right? Again, we see patients who are on antibiotic therapy, which alters their normal body's natural defenses and impairs resistance to some of the harmful organisms that they may be in contact with. Or maybe a patient's on chemo, which lowers their chances of fighting off a bacteria or a microorganism or whatever. Also, the use of corticosteroids and radiation therapy also contribute to healthcare associated infections. So hands are a common vehicle for the spread of microorganisms, and insufficient hand hygiene is an important factor contributing to the spread of these infections. So again, the CDC recommends scrubbing and rinsing for 40 to 60 seconds. Now we're being told in this day of age of the coronavirus to at least wash our hands for 20 seconds. So something that we need to be doing. So just wanted to go over some of the additional reading just to make sure that you were getting the important information from that assigned reading. Let me know if you have any questions. All right, now that we've gone over the reading and you've hopefully viewed that video on isolation techniques, let's match the illness to the type of precautions used. We can choose from airborne, droplet, or contact, and this is in Appendix 14, and it is the concept of immunity, and our exemplar now is isolation techniques. So with strep pharyngitis, which precaution should we use? And the answer is droplet. Measles, and that was stated in your book. Airborne. C. diff. Oh, contact. We know about that. Meningitis. Droplet. Tuberculosis. Airborne. Pneumonia. Droplet. Pertussis. Droplet. MRSA. Contact. Herpes simplex, which could be oral or genital, which is contact. Herpes zoster, which is the shingles, can be airborne or even contact as well. Influenza is droplet, and impetigo is a type of skin problem, and that would be contact. So hopefully you guys understood that and got those correct. So good job with that. All right, I'm going to continue with this lecture on another lecture, video and audio. I've just about used up my hour time with the first part of this. So I will be continuing this with our next case study, Appendix 15. So get that out and be ready to discuss that.